Welcome. I'm Terry Tropin, and today I'm going to talk about the ICD-10-CM guidelines for inpatient and outpatient services. Let me start with information about myself. I have a master's in healthcare administration informatics from the University of Maryland Global Campus, and I have RHIA RHIA and CCSP certifications. I'm also an HEMA approved ICD-10-CM and PCS trainer. I worked for many years, over 20 years, as an adjunct professor at Montgomery College and Silver Spring Tacoma Park campus that's in Maryland. I've also written some books on coding, and here they are. Wrote a book on evaluation and management coding, a book on ICD-10-CM coding, a book on PCS coding, and I also wrote a book that summarizes the changes between the CM and PCS book between 2023 and 2024. Now, all of these books will be updated as soon as I get the 2025 changes. These are available on Amazon, and they're updated every single year. Okay, so what am I going to talk about today? Well, I'm going to talk about, first of all, what is an inpatient and what is an outpatient. And then I'm going to talk about the specific guideline differences between an inpatient and an outpatient. First of all, different terms for what is the diagnosis listed first on the claim form. What's the different terms and why? Then we'll talk about different guidelines for coding an uncertain diagnosis and different guidelines for an abnormal finding on test results, how those are coded in the different settings. Then the guidelines specific to outpatient services for outpatient surgeries, ambulatory surgeries, and observation care. There are also specific guidelines for different types of services usually performed in outpatient settings. Diagnostic services, therapeutic services, preoperative evaluations, and general medical examinations such as annual checkups, well babies checkups, things like that. Okay, so let's start with what is an inpatient and what is an outpatient. Just because a patient walks into a hospital, that doesn't make them an inpatient. An inpatient is an individual admitted to a facility as an inpatient, okay? An outpatient is an individual who has not been admitted to a facility as an inpatient. Okay, that makes sense, but this outpatient may be in a physician's office, but they may also be in an emergency room within a hospital. That's considered an outpatient. An observation area within a hospital, that's also an outpatient. An outpatient clinic within a facility, that's also an outpatient. They may also be in a freestanding clinic within outside of a hospital. You know, all those patient care places that have sprung up all over the place. Those are outpatient clinics. Okay, the Uniform Hospital Discharge Data Set, UHDDS, is the core data set for inpatient admissions. And this will give us the definition of the diagnosis for inpatient admitted, the first diagnosis listed for inpatient admissions. The goal of the UHDDS is to obtain uniform comparable discharge data for all inpatients. It collects information on inpatient hospital discharges for Medicare and Medicaid programs. It looks at patient identification, provider information, clinical information, and financial information. But for this presentation, we're interested in the principal diagnosis definition, okay? The principal diagnosis, according to the UHDDS, is the condition established after study to be chiefly responsible for occasioning the admission of the inpatient to to hospital for care. This is after study, and it's admission. So this is the definition for inpatients, okay? And it's referred to as the principal diagnosis. So for inpatients, they call it the principal diagnosis, and it's for after study to be responsible for the occasioning the admission for care. For outpatient, the UHDDS doesn't apply. Well, the patient's not being admitted, so that makes sense. So for outpatient settings, they don't use principal diagnosis, they use the term first listed diagnosis. Why do they do this? Well, for first thing, not being admitted, so it doesn't make any sense to use the UHDDS. But also, for the outpatient setting, a diagnosis is often not established at the time of the initial visit or encounter. They may not know at that time. They may not have the after study results. It may take 2 or more visits before the diagnosis is actually confirmed. So here's an example. So for an inpatient, you have principal diagnosis. A patient is admitted as an inpatient with chest pains and after study is diagnosed with a myocardial infarction. The principal diagnosis is myocardial infarction. Did the patient with chest pains have a myocardial infarction when they were admitted? Yes, they just weren't sure yet. After study, they said, hey, this patient has a myocardial infarction, and they had it when they were admitted. They just didn't quite know yet, okay? For an outpatient, first listed diagnosis, a patient is seen as an outpatient with coughing and chest pain. Tests were done on the sputum, but no results were immediately available. At the next visit, the patient was told she had a staph infection. For the first visit, the diagnosis is coughing and chest pains. So you're not going to say, in this case, the patient had a staph infection at that first visit. You're going to say coughing and chest pains. That's all you know at that first visit. So that's an important change in addition to just using different terminology, principal diagnosis, first listed diagnosis. Now, the wording used in the documentations for inpatients and outpatients may overlap, may kind of sound the same. When working in the field, it's going to be obvious whether the patient is inpatient or outpatient. But if you've got a test question or a certification exam, it may not be quite so clear. So make sure when you're looking at that whether it's an inpatient or outpatient, because it matters. For an inpatient, they may say admission and then admitted to, and that way you know for sure that the patient is an inpatient. They may also say encounter, which is also used for an outpatient. For an outpatient, say visit, encounter, may say same-day surgery, which is usually an outpatient. Admitted to observation, that's an outpatient, even though they use the term admitted. Seen in an emergency room, that's an outpatient. So keep aware of how it might be confusing. Okay, so let's look at some specific guidelines. Uncertain diagnosis. The guidelines say that a diagnosis may be documented as probable, suspected, questionable, rule out, compatible with, consistent with, working diagnosis, or other similar terms indicating uncertainty. The provider is not sure what's wrong yet. Happens a lot. They may need to do additional testing. They're not sure. You don't want to jump into a diagnosis before knowing what exactly is wrong. For an inpatient, the guidelines say code as if confirmed. Even if it says suspected pneumonia, you're going to code it as pneumonia. For outpatient, it says code the signs and symptoms only. So that's a big difference. So here's an example. An inpatient, patient seen with abdominal pain, provider documents abdominal pain, probable acute gastritis. For an inpatient, you're going to report acute gastritis. For an outpatient, you're going to report abdominal pain. So this is a big difference. This is how it affects your coding. You can see this makes a big, big difference. Okay, here's another guideline difference. Abdominal findings on test results. For an inpatient, a diagnosis is assigned only if the test results are documented by the provider as clinically significant. It makes a difference to the patient's condition and treatment. For outpatient, a diagnosis may be assigned based on radiology or pathology reports. It doesn't have to be documented by the provider as significant. So let's see an example of that. Radiology report from a chest x-ray indicates collapse of a lumbar vertebral body. Patient is asymptomatic. Provider does not document condition is clinically significant. It's in the radiology report, the provider doesn't comment on it. For an inpatient, it's not coded because it's not documented as significant. For an outpatient, the coder can report a code for that, M48.56XA. So there's another big difference. Okay, so some of the guidelines concern specific types of services. So this is outpatient or ambulatory. Some of the guidelines mention these specifically. So what's the difference? Outpatient procedures are typically performed in a hospital or an ambulatory center. So an outpatient surgery or ambulatory surgery. Ambulatory surgery centers are freestanding facilities with operating rooms, but they're not within a hospital. So we're going to talk about outpatient procedures, outpatient surgeries, which are generally within a hospital, ambulatory surgery centers, which are generally freestanding facilities. Okay. Outpatient surgery, the first listed diagnosis is the reason for the surgery, even if the surgery is not performed. So what if the patient comes in and they're not feeling well and the physician says, you know what, we're not going to do this today until the patient feels better? Or what if the provider is not feeling well and says, we're not going to do this because I'm not feeling so well and I'm not up to doing this right now and there's nobody else to do it? What if there's a power failure? What if there's an equipment failure? Other reasons that it's not being done at this time. Even if it's not done, you still list the diagnosis for the reason that it was going to be done, even if it wasn't. So what if it's gone ahead and done? They do this outpatient surgery, but the patient develops a complication afterwards and requires admission to observation. So this is done in an outpatient area of the hospital facility, and then they go into admitted to observation, which remember is also outpatient. First listed diagnosis is the reason for the surgery and then a code for the complication. Okay, for ambulatory surgery, the first listed diagnosis is the reason for the surgery was performed, the preoperative diagnosis. However, if the postoperative diagnosis is established and is different from the preoperative diagnosis, code using postoperative diagnosis, since this is most definitive. Now, often after a surgery, the provider has more information about exactly what's going on with the patient's condition, the exact location, the type of tumor or growth, the type of condition. You have more information about it after the doctor's looked around. So, and about related conditions not known before surgery. So if they have more information, then use the postoperative diagnosis rather than the preoperative diagnosis. You got more information. It's more exact than the preoperative diagnosis. Okay, another guideline for observation, which remember is an outpatient service area. Patients admitted to observation care for a medical condition, the first listed diagnosis is the medical condition. Okay, we also have guidelines specific to kinds of services being provided generally in an outpatient setting. So if the patient is being seen for diagnostic services only, list first the diagnosis, condition, problem, or other reason for an encounter or visit shown in the medical record to be chiefly responsible for the services provided. That sounds an awful lot like the the definition for principal diagnosis on UHDDS that we talked about earlier. Kind of sounds like it to me. So list first the diagnosis, condition, problem, or other reason for encounter, chiefly responsible, okay? Then list any other diagnoses like chronic conditions, okay? But there's an exception. Routine lab radiology testing in absence of signs, symptoms, or associated diagnosis, list code Z0189 or other routine tests for signs or symptoms. So if there's no sign, like routine tests, so like routine mammograms, okay? So in this case, there's a diagnosis, condition, or problem. In this exception, if there's no sign, symptom, or associated diagnosis, you're going to list Z0189. Okay, therapeutic services. This is treatment. So the patient is seen for therapeutic services only. The first listed diagnosis is the diagnosis, condition, problem, or reason for the encounter visit in the medical record to be chiefly responsible for the service. Then list code for any other diagnosis. So why, again, we get back to why is the patient here? They make this more complicated than they need to. Why is the patient here? The patient is seen because of a diagnosis, condition, problem, or reason to be chiefly responsible for why they are here. Okay, then list any other diagnosis. The exception is encounter for chemo or radiology or radiation therapy. So let's list first the Z code for chemo or radiation therapy, and then the diagnosis for the service, the diagnosis. So they're here for chemotherapy, then the diagnosis for the kind of neoplasm that they have, the cancer. Okay, guidelines for preoperative evaluation. A patient may be seen for a preoperative evaluation prior to a surgery being performed by another provider. So the first listed diagnosis is subcategory Z01.81, which is encounter for pre-procedural examination. Then list a code for the condition that is the reason for the surgery. You're doing a preoperative evaluation for what? The surgery. Then any findings found related to the preoperative evaluation. So here's an example. Patient is scheduled for bariatric surgery due to morbid obesity. Excuse me. The surgeon asks this provider for a cardiovascular preoperative evaluation. The provider finds a systolic heart murmur. So the first listed diagnosis is Z01.810, preoperative cardiovascular exam. Then the reason for the surgery is E66.01, morbid obesity, and then the findings is R01.1, heart murmur. Okay, general medical examinations are specific guidelines. This generally is not for inpatients. This is generally outpatient, generally office visit or provided. General medical exams with abnormal findings, Z00.0, Z00.12, include codes for with and without abnormal findings. This is when abnormal condition is discovered during the exam. Again, the definitions of abnormal findings sounds a lot like the definition in the UHDDS. Abnormal findings include conditions, diagnosis, newly identified, or a change in severity of a chronic condition, such as uncontrolled hypertension or an acute exacerbation of COPD during a routine physical exam. So the guidelines say if an abnormal finding is found, first listed diagnosis is a general exam with abnormal findings, then a code for the specific abnormal findings. So first you do medical exam, and then with a digit for, including abnormal findings, and then a code for what the actual abnormal finding was. So here's an example. Examination of a baby at 2 months. It's a general exam. Pediatrician documents failure to thrive. So the first listed diagnosis is general exam with abnormal findings, Z00.121, infant over 28 days. Then code failure to thrive, infant over 28 days, R62.51. Okay, so that's the video. If you'd like a copy of the slides for this video, send me a note with your email address. My email is in the introduction to this video. Send me a note and I will send you a PDF of these slides. For an overview of all the guidelines, see my video on Back to Basics for ICD-10-CM. Again, here are my books on Amazon. You can go to Amazon Books and just type in my last name, Tropin. If you'd like to contact me with comments or questions, there's on Facebook, my email. And remember, my books are updated every year. I hope to get the updates for 2025 this summer. Thank you very much for listening. I hope this is helpful. Thank you.